Good evening, everybody, and welcome to our public webinar on the Hillingdon Hospital Redevelopment. We've broadly got an hour, so there's just a few slides we want to go through, and then at the conclusion of the slides, we'll have time for questions and answers. So if we go on to the next slide. So what we want to do is just go through the key headlines. And so my name is Jason Seed, so good evening. I'm the interim chief executive, and hopefully with the technology working, that's on in the background. I'm joined by Tahir Ahmed, who's our Director of Estates and Facilities, Dr. Abbas Kaku, who is our clinical lead for the new hospital, and then John and Monica also from the Programme Management Office. And so John will be talking on much of the planning we've done to date as well. So they're the team for tonight. I just want to start with a brief overview of where we are. So just in summary, we are one of the 40 hospitals that have been announced for England. So there were announcements in the autumn, which was called the Health Infrastructure Plan for England. And then there was another recent announcement by the government, again, sort of firming up the 40 proposed new hospitals for England. In doing that, we are following sort of the Department of Health and NHS England and Improvement. So they're sort of our two main regulators of NHS trusts, and there's also at the centre the people at the Treasury who control the money. They have sort of very set guidance on the process we need to go through to build a new hospital. In summary, it's a three-stage business case process. So there is a strategic outline case, so that's stage 1, an outline business case, which is stage 2, and then a full business case, which is a stage 3. We've just gone through the strategic outline case hurdle, and so we now have an approved strategic outline case from the Department of Health and Social Care and NHS England and Improvement, and we are in the process of completing our outline business case. So in terms of the headlines that you see on the slide in front of you, these are the key headlines from our strategic outline case. So starting from the left, our preferred way forward is to build our new hospital on the current Hillingdon Hospital site. Our current timeline would see construction start in mid-2022. So referencing back to the business cases again, the next stage is the outline business case, which we are on plan to have ready by summer 2021. We will then look to have our full business case approved by summer 2022, which would lead into us being able to then start construction in 2022. The key headline about building on our current site is our current hospital would remain open during the construction. And we've learned from many schemes that have been sort of undertaken over the last decades about how you really make sure that you operate the services on your current hospital site whilst building a new hospital on the current site. The other piece is we plan to provide the same range of services as now. So Hillingdon Hospital predominantly is a hospital where we provide emergency and urgent care services to our local population. And that's very much what we're planning in the new hospital as well. Just to move on to the next slide. So we thought it might be useful just to go through how our approach is shaped by the national, the sort of sector and the local agenda in the planning of our hospital. So Hillingdon Hospital's NHS Foundation Trust, that's our lozenge in the top right hand side of the screen, and we are very much part of a wider national health service. So when we were speaking earlier about the 14 new hospitals for England, there very much is a push for the 40 proposed new hospitals to work together as an overall programme. And that's very much coordinated from the NHS perspective with NHS England and Improvement and the Department of Health and Social Care. So there's going to be sort of key learning across the 40 proposed new hospitals. So how we design our hospitals, how we're planning things and working things through. So there's very much going to be a joint approach across the NHS. The other piece that we're just highlighting in the middle of the slide is we're sort of part of a local Hillingdon family. So what we want to ensure when we are designing and building our new hospital, that we very much develop joined up pathways for our local patients. So hospitals in many ways are only part of the care that patients are provided with, and we need to make sure that we seamlessly join up with our other partners. The key people being our local authority, so our Hillingdon local authority, our clinical commissioning groups, our local GP Federation, Health for All, also CNWL, who are our local community provider and mental health provider. We sort of come together in something that's called Hillingdon Health and Care Partnership. And that's very much where we all work together on how we can improve services for the local population. At the same time, if you look at the piece below, we're very much moving towards an integrated care system for the wider London, Northwest London economy. So if you look there across all the boroughs, that the key piece for that is how Hillingdon Hospital as an acute hospital works with the other acute hospitals in Northwest London. So as you sort of move around the map towards inner London, you've got Imperial hospitals, so they encompass St Mary's and Charing Cross in the main. You've then got Chelsea and Westminster NHS Foundation Trust, where you have the Chelsea and Westminster Hospital, and then the West Middlesex, and then sort of nearer to us, what is called Northwest London Hospitals NHS Trust, which is Northwick Park, Ealing and Central Middlesex. And very much at the moment, our sort of acute services are provided on a network basis. So for a lot of our specialist services, although we sort of treat people locally at Hillingdon Hospital, for their specialist care, people sort of travel to one of the neighbouring more specialist hospitals for their treatment. So what we wanted to do just here is just to highlight to people about how we're working together, both as part of the NHS, part of our local Hillingdon family of providers, but also working with other acute providers across the patch in Northwest London. So I think I'm now moving on to John. So hopefully through the wonders of technology, you'll stop hearing me and you'll hear John.
Okay, so hopefully you can hear me. Yes, my name's John Mitchell. I'm part of the redevelopment team. First things first, I believe my name above me might be backwards as well. So if there's any issues with the hospital, like the doors are opening the wrong way or the windows, then probably that's down to my involvement, obviously, if this is a starting point to go by. As Jason said, the hospital build that we're looking at, I'm going to take through some of the stages that we've been doing so far, this initial design phase. So this initial slide will show you some of the elements that we've taken into consideration when we're looking at the new hospital and what we have to look at to plan the services that are required and also to deliver on the plans and aspirations of the people of the community. So I'll just go through the sort of the various examples here. So the budget, that's crucial as taxpayers and contributors to the public purse. We're all very aware, yourselves and us, about the need for value for money to make sure that we're using the funds effectively and also delivering what we said we're going to deliver when it comes to the services. So the budget's key. How do we stay in budget? And then the future costs of running the hospital as a result. You don't want to build a really fantastic hospital, but actually it's incredibly expensive to run afterwards. So it's all about the value for money that we look at from that perspective. To determine the type of hospital that we need, we look at population projections, Office of National Statistics and other data sources that we follow up to try and triangulate where the population will be in 10, 20, 30, 40, 50 years time. A complex base of statistics, changing on various aspects. One of the things we've been involved with at the moment is looking at sort of maternity services and what's needed for that. Predicting birth rates is a complicated factor, not just based on the people of childbearing age, but also the fact of the environments that create the ability to have children. So the current climate that we're in economically and also with the pandemic, does that influence it and people's decision making? The new models of care. This is crucial for a new hospital, and this is sort of the overarching element that binds everything together. How do we deliver the services that we want to? How do we access the patients access the services that we want them to at the right time, at the right place, to deliver a fast and effective service for you all? This is often delivered now in the future by digital opportunities. The ability to move forward with technology has progressed at a rapid rate of knots. The fact that now you've got patients with access to systems at home that they can see how their own healthcare is progressing, but also the ability for clinicians by the bedside to access information quickly and effectively. And it's about how we build all those digital opportunities into the models of care. So we don't just do what we've been doing. We don't just carry on providing the same services. The care is the same. The medicine behind it does evolve, but that's still the same. But the actual models that we deliver can be integrated with digital opportunities. Staff involvement is crucial because they're the key to our hospital. When it comes down to the expenditure of a hospital, 70–80% of the costs are always borne by the staff costs. It's crucial that we get their involvement first and foremost to know they've got contacts in other hospitals they've been with, they have their peer groups. Most of the hospital environments have their professional bodies that they link with, so there's best practice to bring through, there's information that they can bring from other services that they integrate with across the community. As Jason pointed out before, we're part of a system, so it allows us to really integrate with our staff colleagues elsewhere to see what best practice we can bring into the new build. Along with the population projections is the activity forecast. Just because we've got a population of X doesn't necessarily mean they'll all require services at the hospital. So again, using modelling, it's to predict the type of services that we need here. Jason mentioned some of the other specialist service providers. It's to know where they fit, but also just to know exactly who's going to come through the front door at various different times of the year. These forecasts aren't necessarily done on a 12th basis. People can come more. Winter's coming now, as we know, so we have different services that require different services then. And in the summer, we have access for other services. Crucially for you as the general public and for us as users of the service as well, most of us use the hospital either at our local hospitals or we have friends and family that do as well. Public engagement is key. You're the people that use the services, you know the pathways that work best for you, so it's engaging with you to make sure that we build a hospital that's right for your services. Once you've got the building, you have to kit it out. The complexities of kitting out a hospital is immense because you've got every piece of equipment needs to be monitored, needs to be quality assured, needs to be maintained, needs to be in the right place, needs to be for the right purpose, and needs to keep up with the technology. So it's needing to have these digital opportunities I mentioned before, making sure the equipment talks to them. It's no use having an old piece of equipment that doesn't talk to one of the computers that then doesn't upload it to the database that the doctor then looks at. So it's all that integration that we need to have to make sure it's all fit for purpose. Future healthcare provision, what's going to be on the horizon for medicine, what's going to be needed when it comes to the population demographics we need. Are we got an aging population? Have we got propensity for certain illnesses that we need to manage in the area? All those aspects need to be managed before we can decide what the final build would look like. And also for you as patients going around the hospital, you want to make sure that you can get to the areas you want to get to the most effectively. You've probably been in Hillingdon, as we all have, where you've asked somebody the direction to one of the wards. If you're unlucky and you've asked me, you're probably still walking around the hospital now trying to find it if I've not pointed in the right direction. But other people may give a more direct route, but we need to make sure that the flow around the hospital is effective. And you also don't necessarily need to see all the workings of hospital. It's a bit like a film studio. When you see it on the TV, it's very slick and finished. That's what you want your pathway to be like when you go around the hospital. In the background, all the cameras are rolling, everyone's running around. That's the same for the hospital. All the portering systems, all the equipment being put to the right place, and all the clinicians running around to the right clinical areas and making sure they're in the right place. That doesn't necessarily need to be at the front of the hospital. So it's about the flow to make sure that you have a calm journey around the hospital to the place that you need to go to for your care. And then it's the available space. We're in West London. There's a premium on the land in West London, so we need to maximise the use of the space so that we can get the best build quality for the size of the footprint that we can get. And available space as well, make sure that we're adjacencies, as we call them, making sure the right buildings are next to the right buildings. So if you've got a maternity unit, which other buildings need to be close to that, or which other departments need to be close to that, to make sure that A, the patient journey is kept to a minimum, but also our clinicians can crisscross between the relevant departments they need, both for their peer reviews when they're talking to their other clinicians, but also there's cross cover required from most of the departments. So designing the hospital is not very simple when it comes down to all these elements. It's a bit like as a child when you used to draw those pictures where you handed it around to your friends, somebody drew the feet, someone drew the legs, and at the end of it you opened it up. If we're asking all our clinicians to design a hospital, it'll look a very interesting picture. It's about them bringing them all together to get an effective service for you as the users and also for the staff to operate in. So I think next slide, Sarah, I think. So how do we go around designing this hospital? At the moment, we have what's called a clinical cabinet. So it's the basis of bringing together 12 groups of clinical groups, well, I say groups, but clinical leaders within the organisation. They're chaired by a clinician, but supported also by a nurse or an allied health professional. They're people like radiographers or pharmacists or therapists. And then we've made those groups up with sort of supplementary, maybe 8, 9, 10 other people from areas that interact in the areas that are highlighted here. So for example, just going around the clock there, we've got emergency and urgent care as one element that feeds into the clinical cabinet. That's chaired by a very senior clinician in the emergency care department, but supplemented with nursing support. The people from the digital team are also into there, and then also other elements of the services that feed in through therapies and pharmacy as well. And the idea is they bring together their expertise and their experience to draw up what the service should look like when it comes down to delivering the clinical strategy that the hospital has. This was a strategy we devised last year about how we as Hillingdon fit into that wider community and the wider healthcare needs of the sector, and what strategy that we can use to deliver the services our patient needs. So these groups are meeting very regularly at the moment. The clinical cabinet meets once a month, but they are tasked at the moment to meet a couple of times a week, the chairs of the groups, to formulate the information they need to make sure that we can design a hospital based on their knowledge. So going around the circle there, I won't go through the detail of them, but emergency care is quite straightforward. It's the front door for most people to come through the hospital. Planned care and cancer, unfortunately, people obviously progress through the hospital to have cancer treatment, so there's a whole group dedicated to that. And also when you come in for your outpatient appointments and your elective care, as it's called, that pathway has been looked at. Surgery and aesthetic care, obviously straightforward for people who then need to go through to theatres. The big one at sort of 3 o'clock is diagnostic imaging. You've all probably come into the hospital or you've accessed services to have some sort of diagnostics, whether it's a plain film x-ray or it could be a scope of some sort. These are the key aspects to diagnose the conditions that people have. And it's becoming more important to make sure that that's done early and also effectively. So that is one of the areas in the new hospital that's probably going to enhance its current footprint and its services based on the need going forward. But that's led by one of our senior radiologists at the moment and supplemented by some of the other oscopies, as we call them. Clinical support, that's an area which captures the elements of sort of pharmacy, pathology, and other elements that feed into those diagnostics that aren't the same as the imaging side. Again, crucial to have fast turnaround of information there, so they're key to the delivery of the pathways that we want to design. Children and young people, straightforward about what they need, but also it's about how we make sure we capture all the people in that age group. Children and young people, there's a transitional ward aspect we're looking at, so the age groups may go up to 18, 19, 20, depending on the needs of the people that are accessing those services. Maternity and neonatal, a little bit earlier on from that, obviously, but it's key as a hospital in the area that we can support people that want to have children, and also the services around that as well. Adult inpatients, straightforward ward provision, and also critical care, obviously the more senior elements of the service required there. The 3 elements in the sort of orange from 9 o'clock till 11 o'clock, they're the enablers as well. So digital we spoke about, they're fully immersed into this process. And actually just from a numbers perspective, they've been collating some of the touch points that the other groups have had from a digital point of view. And currently I think it's 450 examples of digital that these groups have raised that our digital colleagues are now formulating together as a plan as how to deliver this in the new hospital, which is a huge change, but also really reassuring that we're grasping the latest technology and also embedding it into all the planning. Logistics and estates, again, moving forward from maintenance and that aspect to it, but also to the simple fact of how we get things from A to B. So the procurement elements, we can't run any of these other elements of the hospital without making sure all the resources are in the right place. So procurement is key. How do we make sure that we've got the right stock in the right place? And other aspects were under the non-clinical: education and training, research and development, the provision of mortuary services, chaplaincy services, other aspects about a hospital that makes it a real town, as some people call it. One of the design factors about a hospital street that walks through the middle of the hospital. But when you look at the detail and the various aspects we have in this clinical cabinet, it covers a huge range of the hospital skills and expertise. Often when you think of hospitals, you think of doctors and nurses, but actually the reality is there's a huge number of staff that we employ in a variety of areas, and we're trying to get them to feed in as much as they can to what we're going to be deciding the hospital looks like and needs in the future. But yeah, crucially is how the care is delivered is what we're looking to do, what equipment they need, and how we can take advantage of the digital development. So once they've agreed the core principles of what we need, we've engaged with some health planners to look at how this flows through the hospital. And we've actually just come off a good meeting from about 2 o'clock till 5 o'clock this evening, or this afternoon, based on how we put together all these blocks. and it's about providing an ability to look at the shape of the building, not just from the actual physical side of it, but it's crucially these, as we said before, the co-adjacencies. Who sits next to who? Everyone wants to sit next to certain things because they usually work with them. So you want diagnostics very close to the ED department, the emergency care department, but you also need diagnostics near to the outpatient department, but you also need diagnostics near to other elements. And you need to make sure that if people are coming through to the hospital, they can easily pick up their pharmacy. But also you need pharmacy quite close to the ward, so you can make sure that you get the distribution out to them quickly. So it's about planning and blocking them together and working how you build the hospital to get this overall shape. So the expertise that we're bringing in as the health planners, they're allowing us to do that. And as I said, we engaged with 40 clinicians, I would say, on the phone call today to build together this building blocks of what the hospital is going to look like. So it's very much engaged, and it's also a very interactive experience. The beauty of the virtual mediums that we use now as opposed to meetings is we can get people to join in who previously maybe wouldn't because of their geographical limitations, but also it is quite a dynamic environment. There's a chat function where people can question each other. So it's a real good vibe to have in the hospital at the moment about how we can develop the new building. After this has been done, it goes back and forth, as it says on the screen there, which I think is what we probably had today at the meeting. And the architects and planners test the plans. So does it work? Does it deliver what we need for you as patients? And does it feedback from the community? Because it's crucial that we get feedback from you, but also the staff to make sure we work in the plans. You don't want staff finding out that when it comes to their daily job, they've now got to walk more than their 12,000 dedicated steps that we have to do to keep healthy because they've had their co-adjacencies moved further apart than what they used to. You need to make sure that they're going to be efficient as well as the patient pathways. Next one, Sarah. So as I just mentioned there, the feedback from our staff is key. And over the next year, we've got some interesting. Jason mentioned the timeline before. We're looking to sort of mid-22 for the actual the build, but for the next year, we'll be sharing elements of these plans. So the aspects that we're putting together, the design principles, so why are we building, making sure that we're environmentally compliant, making sure we're using the best use of space through standardized room sizes, but also making sure the location for the buildings are right on site. The best bit at the moment for some of our clinicians is seeing sort of artistic impressions. Quite hard to visualize things when it comes to buildings, the stacks. Previously, we've spoken about having things next to each other, but until you sort of see them in a layout, it's quite hard to visualize when it hasn't got windows on it. And as I say, the layout of the hospital we've been looking at. This month, we've been getting some feedback from you through various forums. Car parking and transport is what the current theme is and how we are going to utilise the services that meet that. So whether it's car parking or public transport, that's been sort of inquired about on our feedback survey. It's still open, as the slide says, so please share your views and we'll provide an update on those plans at the next webinar going forward. As I mentioned before, one of the meetings we just had was done virtually, the same format here. This is all obviously due to COVID. The planning we're doing in the hospital now has been geared around COVID. Things have changed a lot from planning hospitals previous to the pandemic. So we're now putting in different provisions for making sure our patients are safe when they visit, but also making sure that our staff are and that the socially distanced compliance are going to be in place. But as a result of this, we're working across different areas of our community in a different way on an online engagement process. So we continue to reach to as many people as possible, but it's a slightly different medium, albeit maybe slightly easier at this time of night. We can come into your houses and homes a little bit easier than you coming out to us. Next slide. So yes, as the slide says, thank you for listening. And I think Sarah fields the questions, I think, through the medium of technology.
I absolutely will. So if you haven't noticed, there's a chat box at the side for the live Q&A. So if you do have questions, please do pop them in there and we'll try and get through as many as we can. So the first question I think I'm going to throw to Jason. Jason, the first question that we've got is about the Mount Vernon Cancer Centre and the fact that it's currently under review and asking the question, could some of those services be located at the new hospital?
Thank you, Sarah. So at Mount Vernon Hospital, there is the Mount Vernon Cancer Centre. That is currently run by Eastern North Herts NHS Foundation Trust. So the sort of QE2 hospital and the Lister Hospital, they're two main hospitals in sort of North Hertfordshire. Most of us can sort of recall over the sort of last couple of decades there has been ongoing discussions across the NHS about the future of the cancer centre at Mount Vernon. The process now has been sort of undertaken by East of England commissioners, so East of England specialist commissioners. So if we think of sort of mainstream hospital services, they are commissioned by our local clinical commissioning group. But for services that are sort of more sort of specialist in nature, they are commissioned by what are called specialist commissioners. And so East of England specialist commissioning are leading a review process at the moment. It is anticipated as part of that process that going forward, the services which are currently run by East and North Herts will transfer to another provider, and currently that's proposed to be UCLH in sort of central London. As part of the process going forward, there will be an options appraisal which will be undertaken by East of England Specialist Commissioning about where would be the best location for future services to be provided. And as part of that, a number of options will be reviewed, and I would envisage one of the options that will be appraised as part of that process is whether some of the new facilities could be built in northwest London, and if they could be built in northwest London, then yes, as the question has highlighted, there is an opportunity for those some of those services to be rebuilt on the Hillingdon Hospital site. But it's going to be part of a sort of very methodical process in terms of options appraisal, where everything will be reviewed. Thank you.
Lovely, thank you, Jason. A question, I think probably for Abbas for the next one, about private rooms. The question was how many private rooms, well, will there be private rooms in the new hospital? Now, I'm not sure whether this is about private rooms as in rooms you can pay for, or private rooms as in single rooms. So if you're able to address a little bit of both, that would probably be quite helpful, Abbas. Abbas, you're just on mute.
Sorry, I'm unmuted now. In terms of private rooms, so at Hillingdon, historically, we have had a very small, what some people may know as Hillingdon consulting rooms. At the moment, there is no plan to increase the private provision of the hospital, and so it'll remain either unchanged or actually there won't be any at all. And it's a very small, service in any case. In terms of the number of single rooms, I think it's a really good news story, because actually the NHS buildings mandate that 50% of your rooms need to be single. At the moment, although it's different according to which part of the hospital you're at, so for example, adults versus maternity and paediatrics, it differs. And of course there's Vernon ward, which is a single room ward. Approximately at the moment, 36% of our inpatient beds, probably slightly less, are single rooms. In the new hospital, the plan is to have a base of at least 50%. That'll be increased to around 70% in intensive care or critical care, and 75% for maternity and children and young peoples. So that's going to be a really good news story for our local residents who use the hospital. Does that answer that question?
I believe it does. Thank you, Abbas. If it doesn't, I'm sure we'll get another question. So I will go to Tahir for a few questions now. So Tahir, if we can start with, so there was a question about how are we taking climate change into account in the new hospital build?
Thank you, Sarah. Yes, indeed, absolutely. The new hospital is very much built in line with key requirements for the environmental considerations It's no secret, it's in fact something where we are putting as our key objective for the hospital is to build in line with a net zero carbon agenda. So climate change is very much one of those key objectives that will help drive our aspirations to become carbon neutral. We are also mandated as a public sector organisation to deliver buildings in line with BREEAM standards, and those are environmental standards as well. Again, we will be aiming for an exceptional or outstanding BREEAM accreditation for this particular hospital. So in short, yes, it's something that we are absolutely passionate about in terms of the environmental considerations, given that the NHS is a large contributor to the local community, and it is important that we build this into the DNA of the hospital, not just for today, but in terms of how the hospital continues to deliver throughout its life cycle and its lifespan as well.
Thank you, Tahir. I'm going to stay on you for a question about just a general update on car parking. And I know we talked about this last time, and we'll sort of go into it in more depth sort of in the future, sort of, because obviously the survey is still open at the moment, but just wondering whether you can give a bit of a feel for car parking during and afterwards, of any sort of key principles around that.
Thank you. Yes, in terms of car parking, our plan is to remain operational. Look, we have a relatively good idea in terms of car parking demand, and which is something that we're keeping a close eye on. We'll continue to maintain where possible those numbers, but car parking is we're in a strange time, particularly with COVID, and of course is very seasonal as well. So people tend to take to different forms of transport, whether it's walking, cycling, or indeed taking public transport, particularly during the summer periods. So what we're trying to do is strike a very fair balance as to the requirements for what the new Hillingdon Hospital will require. There's quite a lot of work to be done because, unfortunately, the restrictions of COVID have not really meant we can model the more up-to-date data currently in terms of car parking, purely because it's somewhat skewed. But what we are doing is looking backwards as well as looking forwards on this as well. So our plan is, as we move forward and with the support of some very good transport consultants and engineers, the hospital will still operate on the existing numbers, but the future demands will be calculated through a car parking demand model as well. So it's work in progress. We're absolutely keen to see what comes through the surveys, and that level of detail is absolutely imperative if you want to get the hospital parking exactly right and be able to serve those staff and visitors, as well as the patients that come and use Hillingdon Hospital.
Thank you, Tahir. Just a couple more questions for you. I'll put them both together. So one is around how long you're expecting the new hospital to last, sort of what's the lifespan that we're sort of planning for. And then there was just one touching again on the continuity during the construction. So just giving a bit more of a feel for how we are able to continue operating during the build.
Thank you. Well, we would expect the new hospital to have a minimum life expectancy of 65 years. Now, that doesn't mean that the building is going to fall down after 65 years. It basically just means that we try to put some sort of understanding to how the asset depreciates as well over a period of time. As part of this, and it was mentioned in John's presentation as well, a key part is how we maintain the building. So what we will do, we will simply ramp up the management of this building and our investment into the building over time as the building ages and as new technologies and new building forms and layouts come on board. The building will, in our opinion, be flexible to be able to adapt to the future needs of the hospital over that period. So it's a little bit bizarre to try and put a timeline on it, but it is equally key that we do that so that we can undertake the accurate modelling as to the type of investment, whether that's maintenance or the long-term capital investment required to adapt buildings going forward over that period. So I hope that answers the first question. And the second part of the question was, remind me again, Sarah, please.
Just about how we continue to stay open during the build, just sort of giving a bit of a feel for that.
Yes, absolutely. The hospital, as it currently stands, does have its own dedicated supplies, and where we're potentially looking at in terms of building the new hospital is the lower serviced part or the engineered part of the hospital. It's largely car parking and a few sporadic older buildings, which, as we move forward with our development plan, we are actually relocating them into more modern temporary buildings at the minute. So the hospital in effect is standing alone anyway and doesn't really get affected by the adjoining site. Jason Sees mentioned earlier at the start of the presentation again that this is not an uncommon practice to build adjacent to adjoining hospitals. It happens across the country, particularly in London, where land is at a premium, and some of the more centrally located hospitals in the city have done exactly that. They've built adjoining hospitals. What we have done is ensured that those experts that have been involved in this type of practice are engaged in our building design and development, so that we again can learn from how best to do this and minimize the disruption, not just to the hospital, but the adjoining buildings and owners and occupants as well. So we're very confident that the processes that we'll adopt will allow the hospital to seamlessly run as it does today.
That's wonderful. Thank you very much to hear. I'm just going to throw back over to Jason now for a couple of questions. The first question is just around why we're not linking up on the Brunel land and building on that site.
Thank you, Sarah. So as part of a strategic outline case, what is required is an absolutely thorough assessment of what is the preferred option for the location of the new hospital. As part of that, there is a very big exercise which is called a non-financial appraisal, and also then a very big exercise which is called a financial appraisal. We went through a process of having a long list of options, which then went down to a short list of options, which then resulted in the preferred way forward. That decision we very much took in partnership. So the options appraisal process was undertaken both by sort of leads from the Hillingdon hospitals, but also from the leads of the clinical commissioning group. The leads from Brunel were also involved, the leaders of the local authority and Health Watch also. So there were a number of parties around the table, and of course other providers such as the GPs and community and mental health. All parties were involved in the options appraisal and taken into consideration all the requirements of our investment objectives. And one of the key investment objectives we had was how quickly can we build the new hospital. So again, we are all so conscious of actually the current failings in our infrastructure at the Hillingdon Hospital. So when you take into consideration how quickly we could do it, the costs, everything else involved, the preferred way forward of all the partners undertaking that options appraisal was a consensus position of the preferred way forward being a rebuild on the Hillingdon Hospital site.
Thank you, Jason. I'm going to stay with you for a couple more questions. So the first one is around the IT systems. Many of our IT systems need updating. How will they be integrated in the new build? Thank you.
So just following on actually a piece about how all these agendas link together, where Tahir was admirably answering earlier about almost the environmental issues concerning sort of big builds. One of the pieces sort of pre-COVID was broadly sort of 2 to 3% of total traffic on our roads in England were people going to and coming back from outpatients appointments. So if you look again this year about how digital has transformed the way we provide services around how we've gone sort of digital, how we've joined up with the GPs. So there is real learning that actually, if we really embrace digital, how it can transform and improve patient care. That very much is driving and underpinning some of the thinking that Abbas is leading in the clinical planning with John. And so that's sort of being embraced in all those groups that were being shown earlier. The other piece with that is there is also sort of the big systems that we are going to be undertaking sort of before the hospital build, but that will absolutely put the new hospital where it should be digitally. So one of the pieces being an electronic patient record. So we will shortly be undertaking a huge project in conjunction with the other acute providers in northwest London for us to put in place digital care records. There's also other areas where digital is enhancing how we provide services. So again, around radiology, but there's also northwest London pathology. But as that technology sort of supports sharing and making sure that everything joins up, that will be working its way through. And again, almost on the small things, when you go to a new hospital, the piece that I think John mentioned earlier, the bit about equipment is huge. And again, the digital piece about how we tie together equipment, all the other digital elements that you can incorporate into a building will transform the way we work in the new hospital.
Can I just add into that as well, Sarah? The NHS digital body, the national body NHSX, has developed a blueprint for new hospitals to follow. And so we're tapping into that information through our leads. As I mentioned before, we've got on our groups, we've got IT or digital representatives on each of our groups feeding into the clinical cabinet. They're all very forward thinking, they're all engaged with the blueprint that's coming out, and that's one of the other elements to make sure that we incorporate anything that's deemed to be a national directive and are going to be across most of the other hospitals that are being developed. We're going to be doing that as well to make sure that we're not going alone. Everything's integrated to ensure that the systems seamlessly talk to each other across hospitals and other patches as well. But yeah, it's one of those areas. So the digital team have been very engaged in the process from the start, and are relishing the opportunity actually to modernise some of the areas that they wanted to do for quite a few years, and now they've got a good opportunity to do that.
That's great. Thank you very much, Jason and John. John, if I can stay with you, just a question about whether the new building will be scalable.
So yeah, I think it was, I think maybe Abbas or Tahir mentioned about the fact of the flexible hospital that we're building, and that's one of the crucial options that at the moment with our planning and our modelling, we can make some assumptions on what we need from a size perspective, but we also need to make sure that the buildings are flexible enough to change their use at a need that's required in the future. Obviously, some of the containments we've had so far, the constraints we've had as a result of the COVID side, is our ability to quickly flip areas into isolation areas in our existing hospitals quite difficult. So the ability to do that and change the functionality of the rooms is key. The flexibility is what's going to be delivered. So the outpatient rooms won't necessarily just be what you would call a consulting room. There'll be treatment rooms. They'll be slightly bigger to allow us to do treatments in there that previously maybe were done elsewhere in the hospital, to bring it into a more daycare environment. So that flexibility and scalability will occur from that perspective, but also the ability to be flexible to move people around the hospital to the right place. So the wayfinding for patients as well, to make sure that they could move. So instead of always going to reception 6 in outpatients, which probably a lot of you have been to, you might be moved to other areas in the hospital, so that if we need to make a bigger area or change things, it can be done with that flexible footprint. And also there is Tahir will probably have the technical term, but the ability to sort of put into soft spaces, which is sort of communal areas and things like that, the infrastructure behind it that can then be exposed later to create other areas that are needed. So for example, we're looking potentially in diagnostics there that you might not need a diagnostic room at the moment, but actually put all the infrastructure behind the walls that's available, and in a few years time when it is needed, we can then take that space and turn it into the use that we need to scale it up to that size. So I think that's there's a technical term to here though, isn't there?
There is, John, and I think it's just if I may add, in terms of those principles, some of our design principles do look at the functionality and the flexibility. So if you look about what some of our design principles are around that, it's about delivering short patient journeys, and that's about keeping the adjacencies right and delivering it in a simple and direct way. But actually what we're also doing is building what's referred to a flexible chassis. And that is not just about horizontal connectivity, it's about principally how do we work horizontally and vertically within a building as well. So this sort of looks at what used to be commonly referred to as that hospital corridor, where you had simply miles and miles in one direction. What we tend to do is look at buildings in a very different way, and that's playing largely to that digital agenda as well, which allows us to provide connectivity in both axes and therefore makes that building more flexible. What we do as part of those design principles is also look at, in terms of that functionality, we look to something referred to as long life and loose fit design as well. So the flexibility does come in around standardization of room sizes and dimensions, but also looks, as John said, is that adaptability. So what we do is build soft spaces, or we build shell and core type areas that allow us to expand the building in a need, or contrast it in reduce it in a way that allows us to sort of work differently if indeed the functional use changes from clinical to non-clinical as well. So horizontal and vertical expansion is what we look at.
Lovely, thank you very much to hear. I'm just going to pass to Jason for a question now. Slightly different topic, but sort of within the same realms. Just around Mount Vernon, and just some questions about the future of Mount Vernon.
Thank you, Sarah. So if we sort of reflect on the sort of progress that we've made over the last sort of 18 months, so there has been a sort of long-standing agenda about a new Hillingdon Hospital for, gosh, at least the last couple of decades. And hopefully what people have heard sort of over the last hour is we are absolutely now positioned to really drive forward and build a new Hillingdon Hospital. We're hoping in sort of quite record speed, and I think that's a fantastic achievement of all our staff and the partnership working and the support of all our local stakeholders. The other piece we are very conscious though as a team is that Mount Vernon equally over the last few decades has had a sort of number of initiatives talked about, but probably it could be summarised as not much has come to fruition. What we've then done is that our clinical services strategy, which we sort of developed in the autumn last year and was approved in sort of spring this year, very much sets out sort of the portfolio of services that we provide at Hillingdon Hospital, but also the services we provide at Mount Vernon Hospital. And with that, it's then how we make sure and drive forward how we provide those services at Mount Vernon. What we've then done is similar to sort of all the planning and work that's happening at Hillingdon Hospital. We're starting a similar process for Mount Vernon. So very much we've got what's called a working group working with the GPs, but also our local commissioning partners and CNWL and others who are sort of involved. What we want to do with that is then look about how Mount Vernon moves forward. In the context of Mount Vernon is quite a big site, and actually at the moment Hillingdon Hospital, so from our perspective, we only use about 10 to 11% of the site. So we touched upon the cancer centre earlier, but there's also private patient facilities. There's Michael Sobel House, which is a hospice. So there's a number of other partners we're talking about how we then come together to very much work through what potentially could be then how we, on an integrated level, develop the Mount Vernon site. So we're hoping sort of the momentum and the robustness of our planning that we put into Hillingdon Hospital over the last year, we're now sort of having a similar approach for the future of the Mount Vernon Hospital also. And just in terms of now, I think I am correct in sort of saying, I think that's the end of the questions, is it? Yeah.
Yes, that's right.
So in summary, there's probably two bits. Thank you on one level for people taking the time to join us tonight and for the expert questions that we've been given. We look forward to continuing these sort of meetings so we can keep you updated, but also take into consideration all the questions people have. Big thank you to the team. So I think it's been a long day for them today. So to hear Abbas, and apologies, Sarah, I did not introduce you earlier. Sarah, who's our communications lead, and John, who's leading on our planning. I think what we want to then do is what we said at the beginning, the outline business case pretty much will be finalising what the design of the new hospital will be. And so as we go forward in these events, it's really to update you all on how the new hospital is sort of taking flesh, and so we can sort of brief you on the sort of the key design principles, but actually start to show you physically how it looks at future meetings as well. So a bit of a rambling ending. Big thank you though to everybody, and we look forward to joining up on another evening. So thank you very much.